Hello, my name is Veronica and I'm with Hughes Nose Nursing, and we are going to do a case study today on respiratory acidosis. But Professor Hughes, I don't like case studies. Well, I encourage you to embrace the case study. I know they can be a little intimidating depending on where you're getting your case studies from, but when you are working in your practice someday, all of your patients are living, breathing case studies. So the more you can practice now and get used to working through case studies, then you'll be able to think critically and more holistically about the care of your patients, because they're not just their symptoms, right? There's a whole lot of factors that play into it, and the case study does a good job of simulating that. So here we go. We are going to talk about, actually, I'm going to use an example from my practice. So I was an ER nurse for several years, and we had some friends that brought in their buddy. He had taken some unknown pill. So something had been put into this pill when they were out at the lake. Everybody took some of what is in this pill, but this particular young man did not react very well to it. So he showed up to us, obtunded, so like really difficult to wake up. We couldn't really get him to wake up to talk to us at all. His respiratory rate was like 10. But very altered, very sedated, and obviously on something that was causing just a decrease in his LOC, decrease in his respiratory rate. So we will start with that as our example. So again, remember, we can't wake him up. Respiratory rate is low. Let's say it's 10, which is a low respiratory rate. Breath sounds are diminished, so just not doing a good job of exchanging air. So for somebody like this, what kind of acid-base imbalance would you think they might have? So do you think it's going to be a metabolic problem, or do you think it's going to be a respiratory problem? Well, it could go either way, but what we're dealing more with is the sedation factor, and that because he's so sedated from whatever it was that he took, he's not doing good gas exchange. So we're going to go with a respiratory cause. From hypoventilation. So not taking good deep cleansing breaths, right? Not doing a good exchange of air. So whenever you don't take good deep breaths, you're going to hold on to what you would usually breathe out, which in our case as human beings is CO2, right? So if I'm not breathing like I should, I'm going to hold on to that CO2. Now, if you remember our Rome mnemonic, respiratory opposite, metabolic equal, as my CO2 level goes up, my pH is going to do the opposite. So as I retain CO2, as my CO2 level climbs, I'm going to get more and more acidotic. So in the case of hypoventilation, I'm holding on to CO2. CO2 acts like an acid, and because of that, it's going to cause that pH level to go down. So for respiratory depression, you're not going to get lots of renal compensation. It's going to take at least 24 hours for the respiratory system to kick in and make any difference. So in a case of acute issue like this, your bicarb is going to be normal. As the condition continues and the body's like, oh, maybe I should do something to fix this acid-base imbalance, you will see the bicarb level start to elevate, or your body's going to start holding on to some base to help it not be so acidotic. So hopefully I didn't lose you completely, but that's okay. We're going to keep going. It's going to be great. Okay, so back to ABGs. What would you expect it to look like? That pH is going to go down because my CO2 is going up. I'm not doing a good job of exchanging air because my respiratory rate is depressed. I have hypoventilation. Also, this is something that happened relatively soon, like recently. He was at the lake with the friends, took something at the lake. They couldn't wake him up, brought him in. It's not like this has been going on for days. So that bicarb level is going to be normal. And then the PaO2, or the partial pressure of the oxygen, is going to be probably less than 80 because he's not doing a good job of exchanging air. Okay. And then what's the treatment in this case? So we always want to think about what can we do. So we got to treat the underlying cause. So did he take opioids? Did he take benzos? We can give treatments to counteract the effects of those things. Also, if he's not doing a good job of protecting his airway, depending on what his Glasgow Coma scale is, we might have to intubate him just to help protect that airway, help with that gas exchange until whatever it is that's in his system is worn off. We need to increase the respiratory rate and depth to help start blowing off that CO2. Because as that respiratory rate stays down, and suppressed, that acidotic state is going to get worse and worse because the CO2 level is just going to continue to climb as that respiratory rate is so low. All right, so respiratory acidosis. It's basically too much CO2. Hypoventilation can cause it, respiratory failure can cause it. Eventually, your kidneys are going to try to compensate by retaining CO2 and excreting hydrogen, okay? So a note about respiratory failure. It can be acute renal failure. The lungs can't get O2 or they can't get rid of CO2. It kind of depends on what the underlying cause is. So you can have hypoxia if you have CHF, where you've got a bunch of fluid that's filling up, so a congestive heart failure, a bunch of fluid that's filling up the lungs that's keeping you from being able to exchange air. You can get acidotic. And that can a PE, same thing. You can't exchange air because you're not getting good circulation because you've got a blood clot that's keeping the blood flow from going through those lungs. So they can have this problem. Atelectasis, so you got a bunch of like just goo sitting in the bottom of your lungs because you're not taking those good deep breaths after like an abdominal surgery or like a big old heart surgery where you've got that sternal incision and you don't want to take good deep breaths because it hurts. COPD can be a problem. They can't blow that CO2 out, right? They're CO2 retainers. Pneumonia. So you get all that infection that's plugging up the lungs. ARDS can cause respiratory acidosis. You have the leakage of the fluid into the alveoli, which can cause direct or indirect lung injury. Other things like sepsis or shock, pancreatitis, near drowning, can all cause respiratory acidosis. And then also SARS, so severe acute respiratory syndrome. So it can be, most likely is lung related, but also can be like a septic situation or a shock situation, which is kind of like a whole body. All right, that is our case study for respiratory acidosis. And further videos, we will do a case study on respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So stay tuned for more content.